Welcome to the Pharmacy Leaders Podcast with your host, Tony Guerra. The Pharmacy Leaders Podcast is a member of the Pharmacy Podcast Network, with interviews and advice on building your professional network, brand, and a purposeful second income from students, residents, and innovative professionals.
All right, welcome to the Pharmacy Leaders Podcast. I'm Tony Guerra, and today I have Dr. Rajeev Kurapati, who practices hospital medicine. He's the author of Unbound Intelligence and Physician, How Science Transformed the Art of Medicine. He holds an MBA from the University of Missouri, and Dr. Kurapati draws insights from scientific knowledge and spiritual wisdom around the world to provide practical solutions to life's most common problems. His articles pertaining to medicine, culture, and lifestyle have been published in Slate Magazine, Cincinnati Enquirer, Mind Body Green, Life Hack, KevinMD, The Good Men Project, and other outlets. Welcome to the Pharmacy Leaders Podcast.
Thank you, Tony. Thank you for having me here. It's a delight.
Okay, great. You said it was okay to call you Rajeev, so we'll go with that and make it a bit of an informal discussion.
Absolutely.
I don't actually read books. I use the audio books. So if I'm referring to chapters or any things, they might be a little out of order, but that's how I make time to listen to books like this. So I wanted to see if you could just first give us a little bit of your personal background about becoming a physician and how that all came about.
Okay, so I'll make it short and sweet. I had this idea, of my when I was growing up at what they call the age of reason, which is about 9 or 10 or 7 or 8, around the time, about 9 to 10 years of age, I developed this inquisitiveness towards human biology. I wanted to know what human body is made up of. Human body is made up of, human mind is made up of, how the interaction happens. So that's how the interest started. And I would go to the hospitals. I would watch these physicians in few seconds come up with an idea of what's wrong with the patient. And in the next few seconds, they're already designing their plan of how to treat it. I was intrigued by this. What goes on in their mind? What's the mystery of their knowledge? And so that's how it all started. It's just basically an extreme interest in how the human biology works. And that's how it started. And obviously from that time, all I wanted to become was a physician, was to become a doctor. I didn't have anything in mind. I was good at art. I used to do oil painting and things like that when I was growing up. But then that was more of a side interest. And so that's how it started. And it naturally led to, going to medical school and this and that. But I grew up in India. I went to medical school in India. After that, I came here. I went to residency in the United States. And then I also did a master's in business administration. I wanted to become a physician later at some point in life. And that's how me and a friend of mine got into MBA program at University of Missouri. And then after finishing it, I got into practice and I do some leadership activities in our hospital. I'm chair of certain committees, and I was the director of our program for a short period before I got into writing. And that takes a good amount of my free time, which I love doing it for writing. So that's quickly. By the way, I have a beautiful wife and 2 little boys, 5 and 4. That's my background in a nutshell.
Okay. Well, tell me a little bit about how the humanities fit in. We'll get into it a little bit later. My undergraduate degree is in English. Tell me a little bit about the humanities. Did that come after you trained as a physician in medical school, or has that kind of remained with you? You mentioned art, but it sounds like the writing piece. What pharmacists want to know is where does that come up, and how do you get good at writing, good enough to become a published author?
Humanities is always part of my growing up. It never left me. I didn't see it as something separate from science. See, when you look at science, what is science? If you question, this was one of the things I questioned when I was writing this book. What is science really? Science is a data-driven investigation of nature. That includes human beings. So when you want to do science on something, you need data. So the science or scientific method starts with a question, an intelligent guess of what you wanted to test, and that we call hypothesis, right? So you have a hypothesis or an intelligent guess, and the next thing you need is data. So that without data, there is no scientific investigation. So humanities, on the other hand, deals with those aspects of human dimension that are not measurable, right? So science cannot reach those recesses of human dimension that are not quantifiable. For instance, how do you measure feelings, emotions, fears, biases, existential crisis, midlife crisis? How do you measure this? There is no way to measure them. This is where humanities come into play. And I did not have any formal, the college degree in humanities, but it was always part of me. Every time I have a human to human, when I have a physician to doctor, which is a human to human interactions, humanities has to be, it's in the word itself. Humanities is a human to human interaction. Science is only a tool for me to know what's going on inside their human operating system. But humanities is what helps me interact with the patient. If I'm lacking on this dimension, then there is no difference between me and a machine treating or dealing with the patient. So as we enter into the age of artificial intelligence and machines and automation, this is what makes you special. In this, especially in the field of medicine, where technologies are rapidly progressing and everything is becoming automated, everything is run by algorithms. So unless you have this human-to-human connection and a huge bit of humanities interplay between you and the other person, which is your patient, there is no. I don't have a role to play there. And that is what the patients earn from a physician. So that's where the humanities come into play.
Okay, well, let's actually make this concrete from a story in your book. You had a story about, I believe, a diabetic patient who asked, "Why me?"
That's right.
And that was, you can bring IBM Watson in, and then the patient says, "Why me?" And I think Watson would have a lot of trouble with them. Can you tell me a little bit about bringing the clergy in as some help for an answer like that or a question like that, and then how it improved patient outcomes in terms of insomnia and those types of things?
Oh, absolutely. So I talk about a patient, a 40-year-old African-American who was admitted and who was about to undergo a major surgery, which is a life-changing one, which is an amputation of his leg because of the diabetic foot infection. So this patient, after going through surgeries after surgeries, he was on dialysis, he was on so many different antibiotics, many specialists, heart valve infection, he was on long-term antibiotics and so on. So he was going through existential crisis. His question to us was, why me? Why am I suffering? What have I wronged? Was his real question. And our answers were rooted in science. Our answers were, you are suffering because you have diabetes. And then he goes on to say, why do I have diabetes? Because it runs in your family. Why does it run in your family? Because their parents had it. So it's an infinite regress. And until a point where, as a person of science, a physician as a person of science, I would say, I do not know why you're really suffering. Because we reach an endpoint where science cannot reach your question, really. It cannot answer why a, a, a baby or a kid had to suffer from cancer, from an incurable cancer. How do you explain this to a parent? How do you tell the parent your kid had, cancer and she's going to die in 6 months? I do not know why. I do not have an answer. And there is a sense of guilt, sense of need for closure for these type of questions in the minds of patients. See, if I have a common cold or a pneumonia or a urine infection or things like that, or a toothache, you don't encounter these type of questions. You don't entertain these questions. But if you have an incurable illness, then a certain sense of existential crisis creeps in. And science do not have answers to this. So when something like this happens in the hospital settings, we bring in a hospital chaplain or a pastor or a priest so that they tap into that dimension of human awareness or consciousness where science cannot reach. And it depends on what part of the world you are in. If you're in this part of the world and your hospital happens to have a hospital chaplain, you bring them in. If you're in the eastern side, you bring in some other priest, of that particular hospital. So you have to have both the scientific side and the humanities side to treat the patient. So that is how I had to bring in the hospital chaplain, and suddenly, in a few days, we started seeing certain changes in this, in a positive way, in this patient, where he's not asking these questions anymore, because he seemed to have found a closure to these questions. Whether they're right or not is a different matter. But he happened to understand that, okay, I'm suffering because of this, and this reason. And then that helped the patient to cooperate with us. And when you psychologically heal, you physically heal. You see that in studies after studies. So that's where this patient comes into the picture. Does it make sense?
Yeah, no, absolutely, and appreciate that. It was just something that really stuck with me. Even a month after I read the book, and how that getting that shock of I don't know, and then being able to say I don't know. Well, maybe let's shift a little bit to working with other health professionals. You're a hospitalist. Tell me a little bit about how you work with maybe nurses and pharmacists within the hospital as a team. You mentioned in the book that before physicians were the pharmacist and the physician, they would dispense the medications. Then that kind of went away, but now it's coming back a little bit where physicians inundated with EHR, copy and paste. People would copy and paste into the EHR, so you have all this to read and not enough time to do things. How do you think physicians are able to best employ nurses and pharmacists to help give the physicians the time they want to do diagnosis, to do the things that they want to do?
That's right. So if you look at, as part of this process in writing the book, I went back all the way to, let us say, 650 BC, where Pythagoras, dating back from Pythagoras to the present and moving into the future. So this book covers the entire spectrum of evolution of medicine and its practices and going into the future. In a nutshell, this doesn't involve enormous detail, but then it gives you a bird's eye view, a good big picture of how medicine has evolved. So with that in mind, if you look at the ancient physician, and let me put it this way: if you look at how healthcare is provided by a physician to the patient, the first step is identifying the problem. We call it diagnosis. And the second step is either, depending on whether it's a surgical or medical, if it's medical, you dispense the drug. So in the ancient past, diagnosing and dispensing was done by one individual. And he was usually a priest and a philosopher too. This person was a polymath. He was all in one. He or she was all in one. So as we reached the scientific revolution in the 16th and 17th century, specialization started to happen. So when specialization happened, we moved from a holistic model of healing to a disease-centric approach. Disease-centric approach is the problem is in the organ, you identify and diagnose it and treat it. So when this happened, enormous volume of knowledge started to unleash upon the physician. And he or she couldn't handle this this volume of knowledge. Specialization happened, and he was responsible for diagnosing and prescribing the medications, but dispensing had to be done by somebody else because of the complexity of the medications that were involved, the interactions between the drugs. The physicians could not handle the specialization and the complexity of the drugs. And so the pharmacist emerged. It is an offshoot of the physician, actually. Of course, the drug makers also collaborated with physicians in the beginning, but then the collaborative agreement had to fall apart. They could not have a financial relationship with each other. So edicts were passed in first Germany, and then that went into Great Britain, and the rest of the Western Hemisphere had to follow certain rules and regulations, how the physicians and the pharmacists work together. So physicians have strictly prescribing role, and pharmacists have strictly dispensing role. But if you see what's happening now, physicians and pharmacists are starting to develop a collaborative agreement again, where the pharmacists are allowed to diagnose and dispense medicines, diagnose, order, test, prescribe, and dispense medicines for a certain conditions. Like, for instance, we have seen anticoagulation clinics, right? It is solely run by pharmacists as providers. So they are the providers for that. So there is no physician involved in it. And see, all this comes to three things in medicine. I'm backing off a little bit here to give the audience a better idea of what all this is about. Healthcare stands on three pillars. One is accessibility, affordability, and quality of care, right? So you have to have good accessibility of healthcare. If I need my INR checked, if I'm on warfarin, and if I have to run to a physician all the time, then there are not enough physicians who can, who has squeeze in that amount of time, and so accessibility suffers. So they have opened up Coumadin clinics and improved the accessibility, affordability. So it's not enough to have accessibility and quality of care if it is not affordable. The third one is the quality of care. So with these three pillars, we see that the collaborative agreements between pharmacists and physicians is only going to expand because we need more providers, and pharmacists are in a unique position because they are part of the team players in a healthcare team, and they are in a unique position to provide not only dispense, but in the future, I spoke to some of the pharmacists in our hospital, and they feel like in the future, for some specific diseases, they will be allowed to diagnose and dispense medications. So, the relationship is very unique and inseparable.
Okay, well, let's. I hate jumping around in the book, but the way that we're talking, I feel like we're going to go to the future. I want to talk a little bit about the AI component of the book, which is closer to the end. But so IBM Watson comes and says that we want to be a partner with you, and this is really your third pillar, the quality of care, and in some cases, I guess it would be affordability. But So, for example, radiologist looks at a film, and then a second radiologist looks at it. You're going to get a better result. But now AI might be that second radiologist. Tell me a little bit about how physicians are looking towards AI as also being one of the partners in improving quality of care.
That's a great question, because it is going to happen. Artificial intelligence is going to take over the roles, some of the roles of the current day physicians. It's already happening. Look at pacemakers. Look at EKG machines in the hospitals. See, they say that the first, like you raised the radiologist example, they say that the first branch or the specialty to get hit by AI is radiology. Why? Because it doesn't involve as much human-to-human interaction as other fields of medicine are. And the one field that is going to survive AI, the invasion of artificial intelligence, is psychiatry or psychology, because that involves human-to-human interaction. So when artificial intelligence takes over, or when it starts to take up more and more duties or responsibilities of the physician, what it really means is it is standardizing care across the continuum using all the available data in that particular field. For instance, if a person goes through a surgery, for example, an appendectomy, right? So when AI comes into picture, it will take in the specific data from that particular individual, compares it to data from all the available data across the medical literature, and it'll take in not just the population statistics. It'll take in, for this particular age group, in this weight range, range, for this climatic conditions, how is this surgery going to affect the person? If the person asks, when can I go back to work, how much weight I can lift, the current standard of recommendation is based on population statistics, and it is only a crude estimation of the reality for that particular surgery. In other words, AI is going to give you personalized data. AI is going to tell you, for you can go back to work in 5 days. But for this other person, he cannot go back to work for 10 days. Because of this, and this reason, we have gathered data from all the other available resources with you in mind. So AI is going to give you accurate, personalized data information based on your metrics. But it is still based on metrics. As we discussed in the beginning of our discussion, science and artificial intelligence is based on those aspects of the care that can be measured. But it is going to give you a whole lot of options. And you need a human professional to interpret the data and apply that data to you. Because at the end, in the end, you have your own beliefs, you have your fears and biases, and you're going through certain crises in life, and you need a human-to-human interaction to interpret the data and provide you with the best possible outcome. So AI is definitely going to take over, but there are certain aspects of the profession that are going to get hugely affected, like the bread and butter practice of primary care physician is going to be hugely replaced by artificial intelligence, but psychology and certain aspects of care are going to survive that.
Okay. Well, let's actually talk a little bit about outcomes. In your book, you talk about how the way that insurers look at something, they look at it as an appendectomy was completed, we're going to pay for an appendectomy, regardless of this is physician's first surgery or this is 20-year physician doing surgery expertly with better outcomes. Can you talk a little bit about how this outcomes model, team-based, is going to kind of change how things are so that, it makes more sense where someone who's been out 20 years provides much better outcome, gets better reimbursement versus getting maybe a lesser quality of care. It's kind of going back to your third pillar again.
Yeah. So what we have now is a person who is fresh out of his residency, he's fresh out of training, is paid the same, paid the same amount for the same procedure as a person who is in practice, very experienced, let us say 25 years into practice. So there is no reward for efficiency. So definitely you can't say the person who is fresh out of residency of 3 or 4 years of training has the same skill as a person who's been doing this for 25 years, right? That is your question.
Yeah.
Yeah. So when more and more data, the big data is collected and put in national registry, when it's more and more accessible to people, they will be able to see how many years of practice, what's their success and failure rate of this physician. And when that happens, automatically, the third-party providers or the insurance companies are going to reward the physicians with the higher efficiency, more experience. I think it should be that way, because what's the incentive? Well, we're talking about the financial incentive, right? So there's always that humanistic reward that your patients thank you for doing such a good job, but then you have to run your practice too. You need the numbers, the finances to meet the overhead and pay the bills and run the staff and so on and so forth. So I feel that the more data we have in the future about the physicians' work practices, and it is going to happen, the more they'll be rewarded. I don't know if I answered your question.
No, you did, and you did.
Okay.
Well, I want to keep this around 25, 30 minutes. Usually people listen to it on the commute. But I want to ask you as maybe a final question is, when I looked at your book and I looked at the chapters, I saw it, and maybe it's biased because I'm teaching in a college, but I saw it as 18 chapters. Oh, that's going to fit nicely into a 15-week semester. Can you tell me what audience you would have in terms of, or what a course would look like if they were to use your book?
Oh, that's a great question. I mean that's.
I didn't mean to catch you off guard. I immediately see a book and it's either it fits well into the semester curriculum or it doesn't. And this one that fits nicely into the curriculum.
I was just taking a couple of seconds to think through, what's the structure. So see, if the way I looked at the book is it's actually two big parts divided into subparts. The first half of the book, or the first 60% of the book, is about the evolution of medicine from a priestly profession to a scientific one. Okay, so how did the priest become a person of science? What changes happened within the scientific community or within the medical community for it to transform from a philosophy into science? Okay, so that's the first half of the book, and so I divided that into how this disruption happened somewhere in the 16th century. So I laid out from 650 BC, from Pythagoras, starting from Pythagoras, in the Greek tradition. So this book is primarily about Western medicine. All right. So this is not. I introduced a little bit of Eastern medicine. The reason why I didn't dwell much in the Eastern medicine is because not much disruptions happened in the Eastern medicine. So if you look at Chinese medicine or Indian Ayurveda or Chinese acupuncture and the holistic healing, not much disruption really happened. They still use the same textbooks that were written 2,000 years ago. But major disruptions really happened in the Western medicine. So how did that transformation happen? What really happened in the 16th century that made them to break away from the 2,000-year-old tradition of humoral practice, which is balancing of fluids, which was started by Pythagoras and his predecessors, and completely disrupt the practice of medicine and break away from tradition and become a scientific one. So that is the first half of the book. The second half talks about different aspects of how medicine changed since that time, since the 17th and 18th centuries. How did the insurance came about? How did the pharmacists profession arose, and how did the nursing change at all for all these 2,000 years? And so the second half of the book talks about the aftermath of the scientific revolution, and the last chapter talks about what's going to happen in the future. And I concluded with some notes to the fellow practitioners. So that is, so the first half and the second half, and then within the first half, talk about the evolution of medicine from a priest to the scientific one, and the second half from the scientific one, from 18th century into the current and moving into the future.
Okay, well, I've asked you a lot of questions. Is there anything you want to say that I haven't asked you about?
I think we covered a lot of subject. I might have gone a little overboard on some of the because once I stop talking, I get very passionate about these topics and kind of go off the tangent sometimes. But I'm glad we covered a lot of topics. Maybe we can have another discussion about some of the things that you felt might help the pharmacy students, or some other aspects of care that we can talk about. Say, some of the things that we might have talked about is how can pharmacy students collaborate with physicians in the hospital? How can they become better team players? Things like that.
Yeah, that sounds good. We'll definitely have to have you back. Well, thank you so much for being on the Pharmacy Leaders Podcast.
So thanks a lot for having me.